Hi guys, welcome for the KNO classes. This is your Nagraj, your NORCET mentor and NORCET guide. I'll welcome you all for the very wonderful session. Okay, I'm here to clear all doubts. Okay, all worries regarding the recent updates. Okay, recent updates of the PPH. Okay, and its management. Okay, all the recommendations of the PPH management and prevention and the diagnosis part. Okay, so without delay, okay, we'll go directly move towards the session. Okay, I think okay, everybody is doing their preparation at their highest level. Okay, because don't okay, we are not having here time to sit and cry. Okay, here we have to put our 100% effort. Okay, then only we'll get the we can anticipate. Okay, we can predict our results. Okay, so I can wait for the results. Okay, I can get the selected like that. So when you wait, okay, when you have the hopes. Okay, when you have given your 100%. Okay, so there is no excuse. Okay, so you should not give any excuse. You should be ready with the 100%. Okay, you should not have any guilt. Okay, any regret should not be there. So if results okay, if result analysis means okay, your result, okay, your name should be there in a list. Okay, so when it will be there, you should have a if you have the full practice. Okay, if you had read out all the syllabus. Okay, you're thorough with the all the revision. Okay, and you're clear with the all concept, then only you can say, okay, you can confidently say my name will be there in the NORCET-10 list. Okay, selection list will be there. Okay, so that you should come in the mindset. Okay, so the positive mindset which should be there. With the positive mindset, okay, you can attend the exam. Okay, it will be very easy. Okay, it will be very easy for you. Okay, if you studied well means it will be very easy for you. If you put a 100% effort means it will be very easy for you to attempt the exams. Okay, so this is the time. Okay, this is the period. Okay, this is a peak time. Okay, you have to put your 100%. You have to push yourself. Okay, you have to push yourself. Okay, more, a little bit more. Okay, you tell to your mind. Okay, now daily I have to study a little bit more. Okay, so I have to extend my study hours more than 2 hours, 3 hours. Okay, I have to push more than. Okay, now I feel okay. Now I'm feeling like I want to sleep. I want to take rest. Okay, again you ready. Like again you read for the 1 hours. Again you read for half an hour. Okay, just try to push. Okay, push yourself for the NORCET-10 examination. Okay, because okay, this if this is the golden period, what I can say is this one is a golden period. Okay, what you will read out in this period, okay, it will be stored in your brain. Okay, so in examination, okay, when you sit in front of a desktop, okay, you'll get the flashes of the ideas. Okay, so just utilize the golden period for your best future endeavors. Okay, so we'll start our today's session. Okay, that is where like part 2 video. Okay, already part 1 I already okay dealt with the PPH prevention. Okay, and antepartum. Okay, and antepartum, how we can prevent the PPH. Okay, now we will see regarding the diagnosis of the PPH, regarding the management of the PPH, regarding the bundle care. Okay, regarding the PPH bundle, regarding the refractory. Okay, if there is not treated. Okay, if the first line management fails. Okay, now it will go for the like a refractory PPH management. Okay, everything will be seen in this all along with that updates. We'll see the all regarding the PPH management and the diagnosis. Okay, so we'll see, okay, from the diagnosis part. Okay, from the diagnosis part, we'll see. So I told you, okay, from the okay diagnosis part, okay, in NORCET-9, okay, so in NORCET-9, they asked the IBQ. Okay, if you given the NORCET-9, you'll be aware of this one. Okay, you'll be aware of this one. So in NORCET-9, they asked it regarding the PPH manager, regarding this drape. Okay, regarding this drape. Okay, this drape name is called as calibrated. Okay, this the drape name is calibrated obstetrical drape. Okay, the name of the drape is calibrated obstetric obstetric drape. Okay, this one is the we call this one as the calibrated obstetric drape. Okay, so this one is specially used to quantify. Okay, specially used to quantify the bleeding in a PPH. Okay, especially soon after the baby delivery. Okay, soon after the placental delivery. Okay, soon after the 15 minutes of the baby delivery. Okay, we'll place the drape. Okay, we'll place this V-shaped drape. Okay, V-shaped drape. Okay, we'll place this V-shaped drape under the buttocks. Okay, under the buttocks of the female. Okay, under the buttocks of the female. Okay, to see the okay to quantify. Okay, especially to quantify. Okay, especially to quantify the amount of the bleeding. Okay, to quantify the amount of the bleeding. Okay, bleeding. So we know that, okay, in a normal delivery, okay, in a normal delivery, normal vaginal delivery, or the cesarean section delivery, there will be some amount of bleeding will be there. Okay, so before and all, okay, will not have any like approximate. Okay, we should before and all we used to measure the blood loss by the approximate. Okay, we used to write, okay, approximately 200 ml blood loss. Okay, we used to write the approximately 100 ml blood loss. Okay, so that is the That is what like that's not like accurate one. Okay, that is not an accurate measurement of the blood loss. Okay, so based on the drape, based on the like pad, how much soaked. Okay, that's why only we used to sell the approximate blood loss. Okay, nowadays, okay, that is been like strictly prohibited. Okay, that approximate measurement is strictly prohibited. Okay, we are not using anymore that approximation. Okay, we want the perfect. Okay, we want the accurate quantity of the blood loss. Okay, soon after the baby delivery means after the third phase. Okay, we can say after in third phase of the labor. Okay, and especially third phase of the labor. Okay, we want to know how much is the actually how much is the amount of the blood loss is there. Okay, so that one only to quantify the blood loss in a third stage of labor. Okay, after the delivery of the baby. So after the delivery of the placenta, we'll place the drape. Okay, and we'll quantify. Okay, here you can see there will be a markings will be there. Okay, this is having a capacity of 2.5 to 5 liter capacity is there. Okay, capacity of the obstetric drape. Okay, obstructive drape. Okay, it's having a measurements are there. Okay, so all the blood. Okay, all the blood from the LSA side, from the vaginal delivery side. Okay, it will be collected into the chamber. Okay, into the calibrated chamber. So we'll measure that one. Okay, based on measurement only, we'll say if there is a more than 500 ml blood loss is there after the vaginal delivery, or else if there is a 1 liter blood loss is there. Okay, after any LSA surgery, we can confirm that one. Okay, the mother is okay. The obstetric. Okay, the mother is having a PPH. Okay, then only we can confirm that one as the PPH. Okay, so I told you when we have to drape this one. When we have to place the drape. Okay, when we have to place the drape. Okay, we have to place the drape. Okay, after the place the drape. Okay, place the obstetrical drape. Okay, place the drape after the exactly after the delivery of the after placental delivery. Okay, we can say after placental delivery we have to place the drape. Okay, oils. Okay, if placenta is not getting delivered. Okay, if placenta is being retained. Okay, more than 30 minutes has been over. Okay, so that's why when we have to consider. Okay, after the so if placenta is not getting delivered. Okay, after the fetus delivery. Okay, after the fetal delivery. Okay, after the fetal delivery 15 minutes. Okay, 15 minutes, more than 15 minutes we can consider. Okay, maybe more than 15 minutes is there. Okay, we can say this one as a written placenta tissue. That time also we can place the obstetric tape. Again, we have to count the we can quantify the blood loss. Okay, so that's regarding the quantifying the quantifying the blood loss. Okay, so now we'll see criteria. Okay, what are the criteria are there to diagnose the PPH. Okay, when we can diagnose. Okay, when we can diagnose the pregnant lady is having the PPH is there or not. Okay, how we can diagnose. Okay, when we can diagnose. Okay, what are the defining features. Okay, what are the defining characters are there. Okay, what are the quantifying blood loss are there. Okay, based on that one only we will diagnose. Okay, whether the mother is having the PPH or not. Okay, we'll see first one. Okay, first criteria is okay here more than or equal to 300 ml blood loss. Okay, more than equals to 300 ml blood loss is there. Okay, 300 ml blood loss is there. Along with not only 300 ml. Okay, we want another feature also. Along with more than 300 ml blood loss. Okay, along with that, any signs of shock. Okay, any signs of shock are there. Okay, any signs of shock are there. Okay, then only we can consider this one as the mother is having the PPH. Okay, so any signs of shock, nothing but the in shock what will be there. Okay, in a shock. Okay, we know that. Okay, the our SBC. Okay, our systolic BP will be less than 90 mm of Hg. Okay, will be less than, or else your DVP, your diastolic BP will be less than 60 mm of Hg. Okay, then only we can say that there is a shock. Okay, there is a shock. Okay, that is one of the feature. Or else we can say hypotension. Along with that, pulse rate. Okay, pulse rate will be more than equal to 100 beats per minute. Okay, we can say tachycardia. Tachycardia and hypotension are the cardinal feature. Okay, cardinal feature of the shock. Okay, tachycardia. If there is any tachycardia and hypotension. Okay, tachycardia and hypotension are the defining features of the shock. Okay, so systolic BP is less than 90 and diastolic BP of less than 60 is indicate there is a shock. Okay, and pulse more than 100 beats per minute it indicate there is a tachycardia. It indicates something blood loss is there. Okay, that's why your heart is compensating for that one. Okay, and third one. Okay, your shock index. Okay, SI nothing but a shock index is more than 1. Okay, more than is 1 is indicate there is a shock. Okay, there is shock. Okay, how to calculate. Okay, then you can ask me, sir, how we can calculate the shock index. Okay, shock index we can calculate. Okay, shock index is equal to is equal to pulse, okay, pulse divided by the pulse divided by your systolic BP. Okay, systolic BP. Okay, if this one will gives rise to the gives rise to this formula will gives the shock index. Okay, if pulse rate is more than 100, okay, your SBP is more than 90, so of course there will be a the shock index will be more than 1. Okay, so that indicates the shock. Okay, this are all the cardinal features of the shock. Okay, if this along with, okay, any feature is there, okay, tachycardia is there, hypotension is there, okay, shock index is more than 1, that all indicate the signs of shock. Okay, so that defines the mother is having PPH. Okay, so more than 300 ml blood loss, along with that any signs of shock are there that indicate, okay, that we can diagnose. Okay, that time we can diagnose the mother is having shock, mother is having PPH or not. Okay, then we'll see. Okay, then another feature. Okay, another criteria. So this one is one of the criteria for diagnosing the PPH. Okay, now we'll see second criteria. Okay, second criteria for diagnosing the PPH. Okay, second criteria. Okay, more than or equal to 500 ml blood loss. Okay, if there is any blood loss, okay, more than more than 500 ml blood loss is there. Okay, that indicate, okay, that time we can diagnose as the PPH. Okay, this one is after the especially this one is after the vaginal delivery. Okay, after the vaginal delivery, if the mother is having more than 500 ml blood loss, that indicate, okay, we can diagnose PPH. Okay, after the vaginal delivery. Okay, this one is we have to keep in mind that, okay, only after the vaginal delivery. Okay, if the mother is undergone for the early stage delivery, okay, so because they will do a like incision and all, they will cut the like minor vessels. Okay, that's why here, okay, we can include the to 1000 ml. Okay, up to near to 1000 ml and more than 1000 ml. Okay, more than 1000 ml blood loss blood loss after the LACS. Okay, after the cesarean delivery. Okay, after the LACS delivery, we can confirm that, okay, the mother is having PPH. Okay, mother is having PPH. And fourth criteria for diagnosing your like PPH is that is your clinical judgment. Okay, if all this fails, okay, if the clinician, okay, the treating doctor will decide, okay, based on the clinical feature. Okay, based on the clinical feature, they will decide, okay, whether the mother is having the whether the mother is having PPH or not. Okay, based on any like creatinine tissue is there, okay, any debris are there. Okay, so that indicate that all clinical feature indicate PPH is there or not. Okay, based on clinical judgment also we can decide whether the mother is having PPH or not. Okay, so this all are the criteria for diagnosing the PPH according to the new update of the WHO. Okay, now we'll see the next one. Okay, next one. Okay, so what all they added? Okay, they added, okay, in active stage of, okay, this is the component. Okay, in active stage. Okay, in active management of third stage of labor. Okay, third stage of labor. So in active management of third stage labor, okay, they removed the uterine massage. Okay, in prevention. Okay, especially in prevention of PPH. Okay, they removed the uterine massage. Okay, I'm specifically telling that, okay, in prevention. Okay, especially in prevention of PPH. Okay, will not include the uterine massage. Okay, uterine massage is not included. Okay, not included in prevention. Okay, prevention, especially prevention of PPH. Okay, so but we can add in the this is added in a management. Okay, in a treatment of PPH. So in this place of in the place of uterine massage, okay, they added the uterine tone assessment. Okay, uterine tone assessment. Okay, so intermittently. Okay, soon after the delivery of the baby. Okay, delivery of the newborn. Okay, they will go for the intermittent uterine tone assessment. Okay, so they will keep a hand on the uterus. Okay, they will assess the tone. Okay, if the tone is soft. Okay, if the tone is soft and boggy. Okay, soft and boggy, it indicates that, okay, uterus is atonic. Okay, it indicates, okay, uterus is atonic. Okay, atonic. So okay, that may be, okay, that may be cause of your PPH. Okay, that time what we can initiate the PPH management. Okay, we can initiate the PPH management. What we can do, we can start with the uterotonic drugs. Okay, next we can go for the delayed cord completion. Then we can go for the like other management. Okay, medical management fails. Okay, then we can go for the mechanical management. Then we can go for the lastly we can go for the uterine artery ligations. Okay, And then if it's soft and boggy, okay, we have to do a uterine massage also. Okay, we have to do a uterine massage also recommended as a treatment. Okay, I'm telling the as a treatment we can add the uterine massage. Okay, but not in a prevention. Okay, so if tone is okay firm and if the tone is firm and hard, okay, it indicate okay uterus is contracted. Okay, it indicate uterus is contracted. Okay, uterus is getting contracted. Okay, uterus is contracted. So no problem. Okay, so no need to no need to not to worry. Okay, not to worry here. Okay, so not to worry. Okay, that's why we are added okay in the WHO PPH management. Okay, they added the uterine tone assessment. Okay, instead of uterine massage. Okay. Next to see as a prevention, okay, as a prevention of postpartum, okay, as a prevention of postpartum, okay, postpartum management of PPH, okay. This one is actually I'm talking about the prevention, okay. Still we are not gone for not gone for the treatment aspect, okay. It's not actually treatment, okay. It is a postpartum, okay, postpartum PPH prevention, okay. It's not management, okay. It's a postpartum PPH prevention, okay. So we can use the uterotonic. Okay, we call that one as drugs used for the increasing uterine contraction are uterotonic drugs. Means the drugs that will uterotonic agents. Okay, the drugs that will increases the uterus contraction. Okay, that's what we call as uterotonic drugs. Okay, so why we need to why we have to worried more about like uterus should be contracting. So because if we see means okay, so if most common cause, okay, most common cause of your PPH is atonic uterus. Okay, most common cause of your PPH is atonic uterus means uterus is not getting contract. Okay, that's the most common cause of your PPH. Okay, that's why we want the uterus to be contracted. Okay, we want the uterus to be contracted. That's why we give a uterotonic agent. Okay, first one to say if you can see the image. Okay, this one is the image of the oxytocin. Okay, oxytocin is the uterotonic drug. Okay, oxytonic is the drug. Okay, so we can use it for the use it as a uterotonic accent. Okay, so what it will do? Mechanism action of the like oxytocin, okay, it like on the receptor, okay, there will be a on uterus, there will be a oxytocin receptor will be there, okay, oxytocin receptor will be there on uterus. So especially on the myometrium, okay, especially on the myometrium, okay, on the myometrium, so there will be a oxytocin receptor will be there. It will stimulate, okay, your oxytocin will stimulate the will stimulate the it will stimulate the oxytocin receptor and it will induce the contraction, okay, and it will induce the contraction, okay, it will induce the uterine contractions. So we know that okay, myometrium plays a very important role in the uterus contraction and relaxation. Okay, so there will be a receptor. Okay, after like especially this oxytocin receptors will be activated after the third trimester only. So during the third trimester we can give a oxytocin injection to induce the uterine contractions. Okay, next to see. Okay, next one. So how we can give? Okay, what is the dose? Okay, what is the dose? You can see the dose. Okay, 10 international units is a dose to prevent the PPH. Okay, to prevent PPH. Okay, so you can see we can give this one through IV route also, through IM route also. We can give through the IV route and through can give to the IM route also. We can dilute. Okay, so diluent. Okay, we should not use. Okay, so we should not use the never use the 5% dextrose. Okay, never use the 5% dextrose for diluting the diluting the for never should be used, okay, for diluting the oxytocin. Because why we should use? Because it will cause the water retention. Okay, if you dilute with the if the 5% dextrose, it will have the water retention power. Okay, that's why we should not use in the 5% dextrose. Okay, so we have to use the NS and the ringer lactate, okay, as the diluent agent. Okay, you should not and more thing, okay, one more thing, okay, we should give this one as the slow IV injection. Okay, we should give a slow IV injection. Okay, so if you're giving the IV bolus, okay, if you want to give a bolus, so it should take up to 1 to 2 minutes. Okay, 1 to 2 minutes should be preferred. Okay, if you're taking more than time, more if you're giving less like fast IV push you're giving means what will happen? There'll be a hypotension. Okay, if you give a rapid push, okay, there'll be a hypotension. Okay, that's why you should be aware. Okay, you should be aware when you're giving the bolus of oxytocin. Okay, bolus of oxytocin, that time you should be aware, you should be conscious, you should count and give IV slowly. Okay, over 1 to 2 minutes you should give. Okay, If we given a rapid IV push, what will happen? There will be a sudden hypotension. Okay, there will be a sudden hypotension because pressure and volumes are inversely proportional. Okay, if the pressure increase, okay, if the uterus contract, the volume means blood volume will be low. So that's why it will cause the hypotension. Okay, that's why you should never give a rapid IV push of oxytocin. Okay, you should always prefer to give a IV slow injection. Okay, IV slow injection, or you can give a infusion. We can put the 10 units of oxytocin in a 500 ml NS or the RL. We can give a orally, we can give a over 24 hours, we can give the oxytocin infusion, okay, to especially to prevent, okay, especially to prevent the PPH. Okay, that's what I'm focusing on. Okay, just why I'm repeating, okay, prevention. Okay, we are talking about the prevention, not about the management of the PPH. Okay, just keep in mind that, okay, not a management, okay, it's a prevention. Okay, it's a prevention of the PPH. So main drawback of this oxytocin is, okay, we have to store, okay, we have to store this oxytocin in a particular temperature. Okay, we have to keep this oxytocin in a cool and dry place. Okay, cool and dry place. Okay, that's why that is the main biggest drawback of this drug. Okay, so we have to store this one in a 2 to 8 degrees Celsius, means nothing but a refrigerator. Okay, we have to keep this one in a refrigerator. Okay, refrigerator. So that's why it's a, if there is a, like, fridge is not available. Okay, if the community area is not having the fridge setup. Okay, that's why we can have another option. Okay, we can have another option. Okay, heat label drug, that is what we call as carbetocin. Okay, we call that one as carbetocin. Okay, carbetocin is the preferred drug. Okay, it's also preferred. Okay, second most preferred drug in a prevention of PPH. Okay, I'm specifically stressing prevention of PPH. Okay, this one is specially used for the prevention of PPH. Okay, PPH. Okay, so also you can see this one is like, why I'm highlighting this one. Okay, when we cannot use the oxidation, that's why we can go for the carbidocin. Okay, it's a heat label formulation. Okay, it's a heat stable formulation. Okay, so we can keep in a higher temperature also. Okay, it's a heat stable formulation. Okay, so we can use under the normal temperature also. Okay, it doesn't require any refrigeration. Okay, you can say this one is a synthetic analog. Okay, we can say this one is the synthetic analog of oxytocin. Okay, as name itself is there. Okay, oxytocin, carbetocin. Okay, oxytocin, carbetocin. Okay, same like that only, means it's an analog. Okay, it's analog of oxytocin. Okay, it's analog of oxytocin. Okay, same as like oxytocin, its mechanism action is same as like oxytocin. Okay, same as like oxytocin. Okay, so what is the main preferred, okay, dose? Okay, what is the dose? How much we can give? Okay, we can give a dose of 100 mics. Okay, as prevention, we can give a 100 mics. Okay, route available. Okay, we can give IV route. Okay, we can give through the IM route. Okay, both route are preferred. Okay, both route are preferred choice for administering the drug. Okay, so this one we can use as the heat stable formulation. Okay, so this also is written as the prevention of PPH. Okay, now next we can go. What is the drawback? Okay, I told you. Okay, we cannot. Okay, if there is a possibility. Okay, if there is a, like, carbetocin is there. Okay, carbetocin is there. Okay, so we need a skilled professionals. Okay, we need a skilled person. Okay, here we need a skilled person means like a doctor or any nursing officers. Okay, we need a skilled person. Okay, if there is a, like, very remote area is there. Okay, very remote area is there. Okay, so with there we cannot have any skilled person. Okay, any healthcare professionals are not there. Okay, any, like, unskilled dayas are there. Okay, unskilled like a birth assistants is there. That time we can go for the, like, oral tablets. Okay, oral tablet of Misoprostol. Okay, that time we can switch for the Misoprostol. Okay, we can switch for Misoprostol. Okay, means nothing but it is a prostaglandin analog. Okay, it is a prostaglandin analog. Prostaglandin prostaglandin analog. Okay, it's especially it is used in the induction and the uterine contraction prevention. Okay, this one is specially used for induction of labor also, and it can use for the prevention of. Okay, this one is especially now we are using for the prevention of prevention of PPH. Okay, postpartum prevention of PPH. We can use the a tablet of Misoprostol. Okay, dose. What is the dose? What is the dose of the Misoprostol? We can use, okay, for prevention. We can use up to 400 mics to 600 mics. Okay, 600 mics can be preferred. Okay, preferred dose. Okay, but low dose. Okay, we prefer to give a low dose. Okay, that's why we can use the 400 mics of Misoprostol. Okay, so we can route. Okay, which route is preferred? I told you, unskilled professional. So we can give the Misoprostol, means, okay, we can give a oral tablet. Okay, we can give a oral or we can give a rectal route. Okay, sorry, we can give a vaginal route. Okay, vaginal route also preferred, or sublingual. Okay, or sublingual or buccal route. Okay, or buccal route. This all route are preferred. Okay, all route are preferred in a to deliver the drug called as misoprostol. Okay, misoprostol. Okay, that's the main thing regarding the misoprostol. Okay, that's why we are added the only three drug. Okay, only three uteronic. Okay, only for prevention of PPH, okay, in a postpartum period, okay, we can give a only three uterotonic, okay, uterotonic agents are preferred, okay, uterotonic drugs are preferred, okay, uterotonic drugs are preferred. That are I told you, only we can use oxytocin, only we can use the oxytocin, or we can use the drug called as mesoprost misoprostol, or we can use the carbetocin. Okay, we can use the carbetocin. Okay, these three things are preferred. Okay, oxytocin, misoprostol, and carbetocin. Okay, only three things are preferred for the management. Okay, preferred for the prevention of postpartum PPH. Okay, next thing, so update guru. Okay, so here we have to focus on, okay, drugs which are not used in prevention. Okay, why I am highlighting prevention? Okay, because ergometrin and sintometrin is used as the treatment. Okay, treatment of for PPH in a refractory period. Okay, in a refractory PPH we can use the ergometrin, but we cannot use the ergometrin in the prevention of the PPH. Okay, we cannot use the ergometrin and the sintometrin in the prevention. Okay, prevention of PPH as the postpartum leave. So why this two, okay, symptometrin and the ergometrin are not used? Okay, because if you see ergometrin, okay, if you see the ergometrin is the is stimulate, okay, in mainly mechanism of action on, okay, it's having a it's going to stimulate the it going to stimulate the your your alpha 1 receptor. Okay, it's going to stimulate the alpha 1 receptor, and it's going to stimulate on an alpha 1 receptor on the blood vessels also. Okay, on the blood vessels also. So what it will cause? It will cause the hypertension. Okay, so we don't want the hypertension. Okay, we don't want hypertension soon after the delivery. Okay, so it's having a side effect. Okay, it's having a side effect of main side effect of ergometrin is the hypertension. That's why we are going to avoid the ergometrin in prevention of PPH postpartumly. Okay, symptometrin and ergometrin both are not used as the prevention of PPH in postpartumly. Okay, and okay, so like what's new regarding the tranexamic acid? So when we can use the ergometrin, I told you we can use the ergometrin in a refractory. Okay, we can use the ergometrin in a refractory PPH case. Okay, means nothing but the when first line management of your PPH fails. Okay, that time we can use the like ergometrin as a choice of agent. Okay, so that's why we are not going to using the ergometrin in the prevention. Okay, so we are keeping the ergometrin as the preserved agent. Okay, as a preserved. Okay, as a backup. Okay, as a preserved agent for choice in a refractory PPH. Okay. And next one, okay, tranexamic acid, okay, it's like we can say it is a anti-fibrinolytic agent. Okay, it is a anti-fibrinolytic agent. Okay, means it's going to prevent the anti-fibrinolytic agent. Okay, means it's going to prevent the fibrinolysis. Okay, what will happen normally? Your fibrin, okay, your fibrins will be broken down. Okay, will be broken down into the will be breakdown. Okay, will be broken down into the like it will be break fibrin is, we know that okay, fibrin will help in coagulation process. Okay, it help in coagulation process. Okay, it will be broken down by the enzyme called as plasmin. Okay, plasmin is going to break the fibrin stand. Okay, so that is mainly, okay, it will going to inhibit the plasmin. Okay, it's going to inhibit the plasmin. Your tranexamic acid. Okay, all we can say pause. Okay, pause is the brand name. Okay, pause is the brand name. Tranexamic acid injection. Okay, it's going to use it as the coagulation agent. Okay, means it's going to use it as the anti-fibrinolytic agent. Okay, especially to prevent the this one is specially used to prevent the bleeding. Okay, prevent the bleeding. Okay, so that time we can going to use the tranexamic acid or the pause injection. Okay, so it's going to process of the plasmin binding agent. Okay, it's going to bind the plasmin and it's going to prevent the action of plasmin. Okay, so that's why fibrins are going to stand in a particular place. So it's going to it's going to arrest the bleeding. It's going to stop and arrest the bleeding. Okay, so that's why, but here, okay, here in a prevention aspect, okay, in a prevention of PPH as a postpartum lead, in a prevention of PPH, okay, we are not going to the pause, okay, the pause or the tranexamic acid, okay, tranexamic acid is not being used, okay, not being used as the prevention of PPH, okay, but in case of management of PPH, we can use, okay, we can use the pause injection, okay, we can use the tranexamic acid, okay. But like we can use, okay, but we can use this tranexamic acid as the management of PPH. Okay, now already PPH has been like diagnosed. Okay, that time we can use the pause injection or tranexamic acid. Okay, all of it clear? All right. Okay, everything is fine. Okay. So okay, chalo. So, okay, be relaxed. Okay, so just sit and relax. Okay, sit and study, sit and relax. So, just see, you can see here. Okay, now next component. Okay, next component. Okay, just will come for the controlled cord traction. Okay, we can say that one as CCT, okay, controlled cord traction. Okay, we call that one as controlled cord traction. Okay, so another name for the controlled cord traction, that is your brand. Okay, brand Andrew technique. Okay, we call that one as the brand we call that one as the brand Andrew techniques. Okay, brand Andrew techniques to remove the placenta. Okay, when there is a okay when there is more than 15 minutes over. Okay, when there is a more than 15 minutes over after the delivery of the fetus. Okay, now still the placenta. Okay, still the placenta is not came out. Okay, still the placenta is been not delivered. Okay, we call that one as a retained placenta. Okay, that time what we'll do if we initiated the active management of third stage of labor. Okay, we can go with the CCT. Okay, we call that one as controlled cord traction. Okay, controlled cord traction. Okay, this one is specially done by the only skilled. Okay, only skilled healthcare. Or we can say only skilled birth attendant. Okay, only skilled, or we can say trained birth attendant only has to perform the CCT. Okay, if there is a no, if there is non-skilled. Okay, if there is no skilled person, okay, if there is no skilled birth attendant is there, so we should not use, okay, we should not use the controlled cord traction. Okay, so why we are not using? Because if you are not having a special skill to have a controlled cord traction, okay, the techniques is not proper, what will happen? There will be a uterine inversion. Okay, there will be a uterine inversion, means uterus will come into the vaginal orifice. Okay, that's what we call as there'll be an inversion of the uterus will be there. Okay, that's what we don't want. Okay, that's the we don't want. Okay, that is the wrong technique. So that's why we are not okay telling that. Okay, if there is a no not skilled person are there, so it's strictly contraindicated. Okay, it's strictly prohibited to use a technique called as controlled cord traction. Okay, so only skilled person can have a controlled cord traction. Okay, so we'll see the technique, okay, proper technique of the controlled cord traction. Okay, proper techniques. Okay, you can see in the image. Okay, proper technique of the controlled cord traction. Okay, what they are doing? Okay, in the opposite. Okay, in the left hand. Okay, they're giving the counter traction. Okay, in the opposite direction. They're giving the controlled cord. They're giving the counter traction, means they are pressing. Okay, downward. They are pressing downward and upward. Okay, downward and upward. Okay, so but okay, so in a one hand, okay, in a one hand, in a first hand, okay, I'm right down here. In a first hand, okay, in a first, okay, non-dominant hand, what you have to do? In the first hand, okay, we have to put the pressure on the abdomen. Okay, we have to put we can say counter pressure. Okay, counter pressure, how it will be? It should be downward and upward. Okay, downward and upward with the non-dominant hand. Okay, so what pressure we have to give? Downward downward and upward. Okay, downward and upward pressure is exerted. That is what we like what we call as counter pressure. Okay, we call that one as counter pressure. Okay, counter pressure. Okay, downward and upward. Okay, downward and upward pressure on the uterus is applied. Okay, second with the dominant hand. Okay, with the dominant hand. With the second hand. Okay, with the second hand we should hold. Okay, we should hold the cord. Okay, hold the cord, and we should pull the okay, we should pull the cord backward and downward. Okay, backward here, backward and downward. Okay, backward and downward. Okay, backward and downward pressure is applied. Okay, so with one hand, okay, with just you see, okay, this one is a uterus. Okay, I'm pressing down. Okay, pressing downward and upward. Okay, the uterus is pressed by the non-dominant hand. Okay, downward and upward pressure applied, and counter traction. Okay, and with the one hand. Okay, I'll hold the cord and I'll apply. Okay, backward and downward. Okay, so downward and backward. Okay, downward and backward pressure I'm applying. With that only I'll get down the placenta will be removed out of the uterus. Okay, So if there is any feel, okay, if there is any, you feel the resistance, okay, if there is any resistance is feel, okay, if there is any resistance is there, okay, that indicate, okay, that time we should, okay, we should not apply, okay, should not apply that time, okay, when you are slowly, okay, slowly withdrawing, okay, slowly with the traction you are applying and you are withdrawing the placenta, that time you will feel any resistance, that time you have to stop the pressure, okay, at that time you have to stop applying pressure, okay, stop the procedure, okay. If you done, what will happen, there will be a retained tissue, okay, there will be a tear of the placenta will be there, or there will be a uterine inversion will be there, okay. That's why if there is any resistance you feel well applying the cord traction, you should stop the procedure, okay. You stop, okay, we can say you should not to apply pressure, okay, not to apply pressure, or we can say stop the procedure, okay, stop the CCD, we can say stop the CCD, okay. Then we can go for the further management, okay. Time you should stop, okay, when you feel the resistance, that time you should stop, okay. The cord should be freely coming out, okay, freely coming out of the uterus, okay. That's what the proper technique of the controlled cord traction, okay. All of you clear regarding the control cord traction? So we are not telling, okay, this according to this update, okay, so non-skilled person should not use the control cord traction, is the update of the WHO 2525 guidelines, okay. So only skilled birth attendant, okay, only healthcare professionals, okay, that they can have the control cord traction process, okay. So that's regarding the one of the, okay, the CCD, okay, control cord traction is the one of the management of your active management of third stage of labor, okay. I told you active management nothing but like within a like delivery of the fetus, okay. So we'll go with the, some procedures, okay, that is what your active like uterotonic drugs, then for the control cord traction, then delayed cord clamping, then we go for the management, okay, surgical management and mechanical management, okay. That's what your active management of third stage of labor means. Will not wait, okay, will not wait for the delivery of the placenta, okay. We'll do something actively, okay. That's what we call as active management of third stage of labor, okay. We'll do some intervention, okay. With the intervention we'll try to take out the placenta out, okay. So I told you, okay, one more component, okay, one more component of the like your active management of third stage labor, okay, that's your delayed cord clamping. Okay, this one is added in a active management of third stage of the labor, okay, and DCC, okay, we can say DCC is added in a prevention, okay, added in the prevention of PPH, okay, prevention of postpartum PPH, okay. So this one, okay, your early cord clamping, okay, ECC is not added, okay, not included, okay, not included in the prevention of postpartum PPH management, okay. So what do you mean by early cord clamping, okay? If you've done a cord clamping, okay, within a 15 to 30 seconds, okay, within the cord clamping, if you've done a 15 to 30 seconds, you've done a cord clamping, okay, you've done the cord clamping. So that's what we call as early cord clamping, okay. So what do you mean by delayed cord clamping? If you're taking the more than 1 minute, okay, more than 1 minute cord clamping, okay, more than 1 minute you taken the cord, you clamp the cord and you cut the cord, we call that one as delayed cord clamping, okay. This one is preferred, okay, your early cord clamping is preferred in a, especially if you want the baby, okay, if you want the baby is in a distress, okay. So this one is preferred in the neonatal resuscitation procedure, okay. You want the baby is getting bradycardia, okay, your baby is getting distressed, okay, that time you want to do a resuscitation, okay, we want to give a CPR, we want to give the drugs, okay, that time we'll take out the baby, we'll do a early cord clamping, we'll take out the baby for the resuscitation, okay. So this delayed cord clamping preferred for the preferred for prevention, okay, prevention of PPH, okay, PPH. And okay, if you see this one, okay, early cord clamping, okay, if there is a any birth asphyxia is there, okay, any birth asphyxia is there, okay, asphyxia is there, okay, that time we'll go with the early cord clamping, okay, and like on some guidelines, okay, NACO guidelines says we should do a, like mother, okay, mother with the, it is like a debatable, okay, we can say debatable, like according to NACO it says we can go for the delayed cord clamping, okay, according to WHO it they says early cord clamping is contraindicated in a HIV. So like when say delayed cord clamping, okay, it will prevent, okay, especially it will prevent the neonatal, it will prevent the neonatal anemia, okay. Neonatal anemia is prevented because if you done the late cord clamping, what will happen? 80 ml of blood will be gone, okay. 80 ml of blood from placenta will be gone to the gone to the newborn. Okay, so by that way, it will prevent the neonatal anemia. Okay, so we are preferring on the delayed cord clamping. Okay, in the management. Okay, in the prevention of PPH, we are going with the delayed cord clamping. Okay, that is main update regarding the BPH prevention. Okay, now we go for the uterine massage. Okay, uterine massage. Okay, I told you uterine massage is okay. Especially it is been okay removed from the uterine massage is being removed from the removed from removed from the your prevention of PPH. Okay, your prevention of PPH. Okay, we have been removed. Okay, prevention of postpartum PPH. Okay, PPH. Okay, so we are removed instead of uterine massage. We are going with the intermittent uterine tone assessment. Okay, we're going with the uterine tone assessment. Okay, I told you. Okay, tone assessment. Okay, we'll intermittently like every 10 minutes. Okay, every 15 minutes we'll go and we'll assess the uterine tone. Okay, if it is soft and baggy, okay, we'll go with the uterine massage. Okay, if it is hard and firm, we'll not apply any pressure. Okay, it says that okay, uterus is already contracted, so no need to do anything. Okay, that's regarding the uterine tone assessment. Okay, that's regarding your uterine tone assessment. Okay, all of you clear? All of you getting? So we'll see. Okay, so this one is like I told you. Okay, before like if there is already uterus is contracted, okay, uterus means okay, there is no need to do any uterus massage. Okay, that's what we can. Another name for the uterine massage is like fundal massage. Okay, we call that one as the fundal massage. Okay, uterine massage is also called as fundal massage. Okay, fundal massage. So that's regarding your uterine massage. Okay, next we'll go with the first response. Okay, first response approach for the PPH management. Okay, so now okay, now we'll come for the first response approach. Means okay, now we come in the PPH treatment. Okay, actually the treatment aspect. Okay, so till now okay, till now we deal with the diagnosis of the PPH and the prevention of the PPH. Okay, now we'll see. Now already mother is gone for the already final blood loss is okay. Already she's bleeding out. Okay, now we diagnosed the mother is having the PPH. Okay, now we'll go for the actual management. Okay, actual management of the PPH. Okay, so first what we'll do, first we'll do a early detection. Okay, we can call that one as early detection of the PPH. Okay, early detection of the PPH. Okay, how we can do a early detection of PPH? Based on the vitals monitoring. Okay, based on the vitals monitoring. Okay, first one is vital signs monitoring. We can say vital sign monitoring. Okay, we can denote. Okay, what will denote the mother is having PPH or not? Okay, where hypotension and the hypotension. Okay, we can focus on the hypotension, and the tachycardia. Okay, two other cardinal features. Okay, cardinal features of the shock, nothing but your PPH. Okay, so we have to carefully monitor regarding the blood pressure and the heart rate of the mother. Okay, so early detection we can do by the vital signs monitoring. So I told you. Okay, now already mother has been like has the so much of blood loss. Okay, already there is a tachycardia and already there is a hypotension. So then we can go with the early. Okay, so then we can go with the large IU so like we have to secure. Okay, because we need to do a resuscitation. Okay, we know that okay, hypotension. Okay, first line management is we have to give the IV fluids. Okay, we have to give the IV crystalloids. Okay, we have to give. So that's why we have to secure the IV cannula. Okay, we have to secure the IV cannula should be secured. Okay, we have to secure the IV cannula. We can say large bore IV cannula. Okay, large bore IV cannula. Especially if large bore IV cannula means 18 gauge. Okay, preferred is 18 gauge IV cannula. Okay, two IV cannulas. Okay, two large bore IV cannula should be secured for administering the inotropes and the crystalloids. Okay, so next one after securing IV cannula, we have to give a IV fluids. Okay, IV fluids administration. Okay, so how much? 2 liters. Okay, up to 2 liters is permissible. Okay, up to 2 liters of crystalloids are preferred. Okay, in the starting we have to prefer the crystalloid solutions are preferred. Okay, then this one I'm telling you, okay, this one is non-specific management. Okay, for any case of EPH, okay, we have to do a like non-specific management. Okay, general measures to manage the first response to manage the PPH. Okay, and then when arrange for the blood products. Okay, we can say okay, we should anticipate. Okay, now we are early detecting the PPH. We have to arrange the blood and blood products. Okay, we have to arrange for the blood and blood products. Okay, I told you why I'm telling blood and blood products, because we don't want only the PRVCs. Okay, we want the FAPs, we want the platelets. Okay, because we want the bleeding to stop. Okay, so blood and blood products should be arranged. And next one, okay, Foley's catheterization. Okay, we can say that one as Foley's catheterization. Okay, Foley's catheterization. Okay, why we are preferring Foley's catheterization? Okay, why we have to catheterize the patient? Because we know that okay, your full bladder. Okay, so what will happen if there is a mother is having the full bladder? Okay, due to the pain, she is not voiding out. Okay, if the full bladder is there, means okay, it denotes okay, it says that okay, full bladder will compress. Okay, will suppress. We can say will compress the contraction. Okay, will compress the uterine contractions. Okay, will suppress. It will compress and it will suppress the uterine contractions. Okay, uterine contractions are suppressed by your full bladder. Okay, that's why we have to catheterize. Okay, we have to catheterize. We have to empty the bladder. Okay, we have to empty the bladder. Okay, then to say then we can do a like HB test. Okay, we can do a HB complete blood count. Okay, and then we can do a cross matching. Okay, cross matching of blood products. Okay, cross matching we can do for the blood product transmission. Okay, that is the main like first response for the PPH treatment. Okay, now we'll go for the like a specific management. Okay, now so we can call that one as okay first response for management of PPH. Okay, there is a bundle. Okay, bundle nothing but a set of intervention. Okay, we can say a set of intervention. Okay, set of intervention for PPH. Okay, for managing the PPH. Okay, now we'll see. So I told you like it's a bundle. Okay, so it contains so many set of intervention. Okay, we can call that one as M. Okay, M for motive. Okay, motive we can like a mnemonic, by the mnemonic we can remember motive. Okay, MOTI motive. Okay, motive. Okay, IV motive. Okay, motive is the like mnemonic. Okay, for remembering the like a treatment bundle for the PPH. Okay, so motive. Okay, motive is a mnemonic. Okay, motive is a mnemonic for remembering the treatment bundle of PPH. Okay, M for massage. Okay, so I told you. Okay, I'm repeatedly telling. Okay, the massage. Okay, uterine massage is part. Okay, is the important part of the treatment of PPH. Okay, not the prevention. Okay, not including the prevention of PPH. Okay, massage nothing but the uterine massage. Okay, uterine massage is indicated. Next to see O for the oxytocin. Okay, O for the oxytocin drip. We have to start. Okay, we have to start here. IV. Okay, we have to preferred is IV route. Okay, preferred is IV oxytocin. Okay, next to come next to come for the like a T aspect. Okay, so T aspect. Okay, so in that okay oxytocin we have to start with. I told you preferred is IV because we want a faster action here. Okay, that's why preferred is IV. Okay, IM is least preferred. Okay, that's what like oxytocin is preferred to give a IV route. Okay, T for the tranexamic acid. Okay, T for tranexamic acid. Okay, tranexamic acid. Okay, so we know that. Okay, I told you. Okay, in the management. Okay, in the management, tranexamic. Okay, our antifibrinolytic is a main drug of choice. Okay, so 1 gram will give. So this one will given in the 100 ml NS. Okay, we have to 1 gram of tranexamic acid added in the 100 ml NS. We have to give a slow infusion. Okay, if you give the fast infusion, what will happen? There will be a thrombolysis will happen. There will be a thrombus of the vein will be there. Okay, that's why we have to dilute the tranexamic acid in the 100 ml NS. Okay, we have to dilute in a 100 ml NS. We have to give a IV slow. Okay, that's regarding tranexamic acid. Okay, we have to give now. Mother is confirmed with the PPH. Okay, as a treatment aspect, we have to give the 1 gram of tranexamic acid. Okay, so if bleeding if still will is not stopping. Okay, after 30 minutes. Okay, we will wait for the 30 minutes. First, we will administer the 1 gram pause injection. We will wait for 30 minutes, and you can say okay if the bleeding is still persistent. Okay, then we can give a repeat. Okay, then we can repeat 1 gram, when we can repeat the 1 gram tranexamic acid. Okay, we can repeat the dose of tranexamic acid. Okay, then like next choice is IV fluids. Okay, I for the IV fluids. Okay, I told you crystalloids are preferred. Okay, we can give a crystalloids. Okay, crystalloids are preferred in the management of PPH. Okay, and E for the like most common cause. Okay, I told you like one of the cause of your PPH is like any trauma. Okay, any trauma to the genitourinary tract. Okay, so if there is any like exam. Okay, we have to do a examination of genitourinary tract. We can say genito genitourinary tract. Okay, genitourinary tract examination. Okay, we have to add the genitourinary tract examination. Okay, why? Because if there is any cut, okay, if there is any perineal tear is there, okay, any vaginal cut is there, that indicate, okay, the mother is prone to have a postpartum hemorrhage. Okay, that's why we have to do a careful examination of genitourinary tract. Okay, and then, okay, if it's all management fails, okay, but if all management fails, okay, if oxytocin fails, okay, if IV fluids fails, okay, everything fails means, okay, that time we have to escalate the care. Okay, we have to escalate the care. Okay, escalate the care, nothing but we have to go for the further like surgical management and the mechanical management for your PPH bundle. Okay, that's what like PPH. These all are the like important, okay, so important segments of your PPH care bundle. Okay, PPH care bundle. Okay, next we'll see. Okay, I told you, like, if all is management. Okay, so we'll see medical management. Okay, first we'll go with the medical management of PPH. Okay, medical management of PPH. Okay, first I told you, okay, uterotonics are preferred. Uterotonic drugs. Okay, uterotonic drugs are preferred. Okay, uterotonic agents, you can say. In that uterotonic agent, okay, we'll prefer to give a first one. I told you oxytocin we can give. Oxytocin is the first line of choice. Okay, first line of choice. Same. Okay, 10 units. Okay, international unit. Okay, we can give a IV is preferred. Okay, then we can go with the, then here we can go with the carbetocin. Carbetocin. Okay, here we have to increase the dose. Okay, 200 mics. Okay, 200 mics is preferred. And then, okay, misoprostol here. Okay, misoprostol also can be given. Misoprostol also preferred to give to prevent. Okay, as a management of misoprostol. Okay, misoprostol is preferred, but here this dose is 800 mics. Okay, 800 mics is the preferred route. Okay, preferred dose. Okay, if it is a refractory. Okay, if it is a refractory PPH is there, we can go with the ergometrin. Okay, we can go with the ergometrin. Okay, we can go with the ergometrin. I told you it's preferred. Okay, it is not preferred. Okay, it is a reserved. We can say it is a reserved in a, especially reserved. We want to keep some reserved drug in a refractory PPH. Okay, it's reserved in the refractory PPH. Okay, this may be a NORCET question. Okay, they may ask you regarding the drugs used in the refractory PPH. Okay, that's your ergometrin. Okay, ergometrin. Okay, this one is a 0.5 mg is used. Okay, 0.5 mg is used. Okay, so that's we can give. Okay, then I told you tranexamic acid. Okay, tranexamic acid or antifibrinolytic drug. Okay, tranexamic acid is the main medical management of choice in the PPH. Okay, first we'll give of 1 gram in a 100 ml NS. Okay, in 100 ml NS. Okay, we'll give. Then we'll wait for the 30 minutes. Okay, we'll wait for the 30 minutes and we'll wait to see blood bleeding is stopped or not. Okay, if there's again continued bleeding is there or continued bleeding is there, we can repeat. Okay, repeat the dose. Okay, repeat the dose. How much we have to repeat? Okay, we have to give 1 gram. Okay, 1 gram again in 100 ml NS. We have to repeat the dose. Okay, repeat the dose of tranexamic acid. Okay, that's a like special basic management of basic medical management of your like PPH. Next to come. Okay, now again, like if you tried with the medical management. Okay, and if you waited for, if you done a like if given the uterine drugs also. Okay, still the placenta is not coming out. Okay, then we can go with the manual removal. Okay, we can say MORP. Okay, manual removal of the placenta. Okay, we call that one as manual removal of the placenta. Okay, that's what we call as MORP. Okay, MROP, nothing but the manual removal of the placenta. Okay, here what will happen? Okay, here there is a, because we are putting, okay, we are directly inserting our hand into the uterus. Okay, so that's why here there is a like foreign body is entering in the uterus means, okay, so of course there will be chance of infection is there. Okay, if those there is a chance of more chance of infection. Okay, that's why like, update regarding the MROP. If you want to do a MROP in case of, okay, all management fails. Okay, or all management, okay, all your first line and second line management fails. Okay, if your management of PPH, okay, PPH fails, normal management. Okay, then only we have to go with the manual removal of placenta. Okay, so since it is having a high risk of infection, we have to give a antibiotic prophylaxis. Okay, we have to give a, that's main regarding the like update. Okay, so in the update of the like 2025 EPH guidelines, okay, they will say antiprophylaxis should be given. Okay, antibiotic prophylaxis is preferred. Okay, antibiotic prophylaxis given before the like before 1 hour or before 1 hour of manual removal of before MRF you have to give. Okay, which one is preferred? Okay, before antibiotic choice is like first generation cephalosporins. Okay, first generation cephalosporins. Okay, we can say, so that is your like ceftriaxone. Okay, but ceftriaxone is, sorry, So first generation cephalosporins are preferred in a in the antibiotic, okay, prophylaxis of antibiotic choice in the MROP. Okay, so that's one is preferred. Okay, that's one is preferred. Okay, so first generation cephalosporins, that is your citraxone. Okay, citraxone. Zone, okay, zone 1 gram. Okay, so zone 1 gram is preferred. Okay, second preferred antibiotic of choice is a ampicillin. Okay, that is your ampicillin is also preferred in the prophylaxis of the MROP. And this one, okay, this one is a painful procedure. That's why we have to do in a this one procedure is done in the OT. Okay, we have to do a procedure in the OT. Okay, with the general anesthesia. Okay, procedure in a under the general anesthesia. Okay, under the general anesthesia or the under the regional anesthesia. Okay, under the regional anesthesia or under the epidural. Okay, epidural anesthesia also we can go with the MR. Okay, epidural anesthesia. Okay, some anesthesia is required for the like manual removal of placenta. Okay, that's regarding MROP update. Okay, and next to say, okay, surgical management. Okay, next to coming for the surgical management of your PPH. Okay, so first line management fails. Okay, for first line management fails. Okay, first line management of PPH fails. Okay, PPH fails, then we can go with the second line management, that is your surgical management. Okay, here you can see uterus. Okay, they are sutured the uterus. Okay, in a round way. Okay, we call, if you just see, if this one is the your uterus. Okay, uterus is there. Okay, and then uterus. Okay, you are doing the suturing. Okay, you are doing the uterus suturing. Okay, so we are doing the round the way you are doing the suturing. Okay, we call that one as B-link. Okay, we call that one as B-link B-link suture. Okay, B-link suturing is done to, okay. So B-link suturing you done means, okay, it will compress the uterus. Okay, so what it will done, it will do, it will compress the uterus. Okay, it will compress the uterus. So if it is compressing, so what will happen? So bleeding will stop. Okay, so it will stop the bleeding. Okay, it will stop the bleeding. Okay, that's the mainstay of surgical management of your PPH. Okay, next to say, if this one is specially, okay, this one is specially recommended in, this one is specially recommended in, sorry, this one is specially recommended for family is not completed. Okay, if the female is, okay, if the female is having the only one child. Okay, or two child is, okay, family is incomplete means, okay, means she further requires a pregnancy means, okay, that time we can go with the B-link suture. Okay, keep in mind that, okay, very important. Okay, B-link suture is preferred as a surgical management of choice. Okay, next one to say, okay, next surgical management is like they can go with the umbilical art, sorry, uterine artery embolization surgeries. Okay, and they can go with the hysterectomy. Okay, they can go with the like last management. Okay, hysterectomy. Okay, if the family is completed. Okay, if the family is completed, they will go with complete. Okay, we can go with the complete complete removal of the complete removal of uterus. Okay, they will go with the uterus. Okay, if the family is completed means, okay, if the family is completed. Okay, if the family is completed, okay, it's safer to go with the hysterectomy. Okay, if the family is complete means the mother doesn't want any future baby means, okay, they can go with the hysterectomy surgery. Okay, if this one especially is done for the like all management fails. Okay, if all management fails. Okay, your all management fails. Okay, your all management of PPH. Okay, first line, second line, all management fails. All management fails, they will go with the they'll go with the hysterectomy. Okay, next one. Okay, based on research. Okay, based on research. Okay, direct injection. Okay, direct administration of oxytocin into the umbilical vein. Okay, so umbilical vein, what will happen? So umbilical vein, we know that, okay, it will go to the placenta. Okay, it will go to the placenta. So what will happen if you give the oxytocin? Okay, if you give the oxytocin directly into the umbilical vein, it will go to the placenta. So what is the main benefit? Okay, it's having the more sensitivity. Okay, more sensitivity for the more sensitivity to sensitivity and more specific. Okay, we can say it is more sensitive and more specific. Okay, it will reach to the directly, it will reach to the target tissue. Okay, target tissue. So what we can anticipate, we can anticipate the more action is anticipated. Okay, more action of oxytocin is more action is anticipated. Okay, that's why we are preferred, more action is prefer anticipated. Okay, anticipated. Okay, anticipated. anticipated. Okay, that's why we can have a trial of, okay, we can have a trial of oxytocin direct admission into the umbilical vein only. Okay, that's also based on research. Okay, they added the umbilical vein administration of oxytocin, okay, as the management of your PPH. Okay, now one more word is there. Okay, one more category is there. That's what we call as a refractory PPH. Okay, we call that one as a refractory PPH. Okay, there is a term called as, okay, PPH. Okay, now we'll see the what are the updates regarding the refractory PPH management. Okay, so before management, okay, before management, you should know what do you mean by refractory PPH. Okay, if the blood loss, okay, if the blood loss, if there is persistent, we can say if there is persistent, if there is persistent severe blood loss. Okay, if there is a persistent severe blood loss is there. Okay, severe blood loss more than, okay, more than or equal to 1 liter. Okay, more than or equal to 1 liter. Okay, 1 liter blood loss is there. Okay, even after the, if bleeding is not stopped, even after the, even after first line management. Okay, even after first line bleeding is not stopped, even after first line management of, okay, first line management of PPH. Okay, first line management of PPH, we call that one as a refractory PPH. Okay, nothing but a, let's just say nothing but, now, okay, now already PPH is, has been done. Okay, already diagnosed. Okay, now more than 1 liter blood loss is happened already. So they will start with the first line management. Okay, first line management. Okay, what is the first line management of PPH? What is the first line management of PPH? So first I told you, okay, first component is, okay, first one is uterine massage. Okay, if there is a, if there is any like incidence of PPH, okay, they will go with the uterine massage. Okay, uterine massage, and then, okay, they will administer the administration of uterotoning drugs. Okay, uterotoning drugs. Okay, so if both, okay, after giving both this also, if there is a bleeding is not stopping, okay, if there is again continued bleeding is there, we call that one as the, we call that one as a refractory PPH. Okay, now we'll see the what are the updates regarding the refractory PPH. Okay, so the refractory PPH will go with the mechanical methods to methods to prevent the refractory PPH. Okay, refractory PPH. Okay, so here you can see, okay, with the one hand, okay, they are compressing, okay, they are compressing the uterus, and inside the uterus, okay, they are inserting one more hand with a gloved hand, they are compressing the uterus. Okay, we call that one as, we call that one as bimanual compression. Okay, we call that one as bimanual compression of uterus. Okay, we call that one as bimanual compression of the uterus. Okay, that is a management used as the, like, one side. Okay, with the one hand they're compressing, okay, on above, on top of the uterus. Okay, they're compressing with the one hand, and another hand inside the uterus. Okay, they inside the vagina, they insert it into the uterus. Okay, they're compressing in between the hands. Okay, we call that one as a bimanual compression of the uterus. Okay, and then to go with second management, okay, as a mechanical management. Okay, that's what we call as uterine balloon tamponade. Okay, we call that one as uterine balloon tamponade. Okay, we call that one as uterine balloon tamponades. Okay, means nothing but the, like, Bakri balloon. Okay, we call that one as Bakri balloon therapy. Okay, we call that one as Bakri balloon. Okay, Bakri balloon is being used. Okay, so we'll directly insert the Bakri balloon inside the uterus. We'll compress the uterus inside. Okay. So mechanical management. Okay, in mechanical management, okay, first one I told you, we can put a tungsten Blackmore tube. Okay, we call that one as SBT. SBT is nothing but a tungsten Blackmore tube. Okay, tungsten Blackmore tube, or we can use the Bakri balloon. Okay, we can use Bakri balloon. Both, what will happen? Okay, we'll insert the device. Okay, insert the balloon. Okay, insert the balloon inside the uterus. Okay, inside the uterus. Okay, after that, what will happen? Okay, how to inflate? Okay, how to inflate the tungsten Blackmore tube or the Bakri balloon? Okay, inflate with the 300 ml NS. Okay, 300 ml NS should be inflated. Okay, with the inflated, what will happen? So it will exert. Okay, that 100 ml NS. Okay, it will exert the pressure. Okay, it will exert the pressure on the uterus. Okay, by that exerting and the pressure on the uterus, okay, there will be a, it will stop the bleeding. Okay, it will stop the bleeding. Okay, it will stop the bleeding. Okay, that is the main mechanism of the Bakri balloon or the Sunction Blackmore tube. Okay, that's when we can go and we can use the condom catheter. Okay, we can use the sterile condom catheter. Okay, condom catheter. Okay, condom catheter is also used. Okay, so same thing. Okay, say up to 300 to with the insert, we have to insert the condom catheter into the uterus. Okay, we have to inflate with the 300 ml NS. Okay, we have to inflate with 300 ml NS. Okay, so it will exert pressure on the uterus. Okay, that will compress the uterus and it will stop the bleeding. Okay, so ultimately we want the uterus to be compressed. Okay, and next one. Okay, so again this all is fails. Okay, again our mechanical method fails. Then we can go with the external aortic compression. Okay, we can go with the external aortic compression. We call this one as the, in short form we call that one as EAC. Okay, EAC, nothing but the external aortic compression. Okay, we call this one as the life-saving procedure. Okay, it is, you can call this one as life-saving procedure. Okay, life-saving procedure. Here what will happen? Okay, so with the using of the clenched fist. Okay, so with the dominant hand. Okay, what will happen? Okay, with the dominant hand. Okay, the surgeon. Okay, the surgeon, what will happen? They will make a fist. Okay, they will make a fist. Okay, they will make a fist. Okay, with the elbow straight. Okay, with the elbow straight, they will directly compress on the abdominal aorta. Okay, they will directly compress. Okay, they'll on the abdomen. Okay, on the midline of the abdomen. So just consider. Okay, this one is the abdomen. Okay, this one is the abdomen of the mother. Okay, this one is the umbilicus. So they will draw a midline. Okay, midline will be there. Okay, so from the midline, okay, they will here exactly on the just 2 centimeter below the just 2 centimeter below the umbilicus. They will keep the fist of the hand. Okay, with the elbow straight. Okay, will exert the shoulder pressure. Okay, they will lean bend on the patient. Okay, so with the using the shoulder pressure. Okay, with the elbow straight, with the clenched hand or clenched fist. Okay, they will exert the full pressure on the abdominal aorta. Okay, the life pressing pressure in a refractory shock. Okay, in a refractory PPH. Okay, so all management fails. Okay, so now mother is losing so much of blood loss is there. Okay, that time they'll go with a life-saving procedure called as external aortic compression. Okay, external aortic compression. Okay, why they have to compress aorta? We know that okay, abdomen aorta is going to give a supply to the common iliac artery, internal iliac artery, and uterine artery like that only. So if you compress the main branch only, so there will not be a blood supply will be there. So that's why. So there will be a chance of blood stoppage will be there. Okay. So key points are okay. Key points. Okay, elbow straight. Okay, while procedure we have to do a elbow should be straight. Okay, so points are elbow should be straight. Okay, elbow should be straight. Okay, and we should make a fist. Okay, we should make a fist and we should use the shoulder pressure. Okay, we should use the shoulder pressure should be used. Okay, how we can use the shoulder pressure? We can bend on the we can lean. Okay, we can lean or we can bend on the patient abdomen. Okay, that is what your external aortic compression. Okay, next one as a management of shock. Okay, as a management of shock we can use the non pneumatic. Okay, anti shock garment. Okay, anti NPAS. Okay, NPAS nothing but a non pneumatic. Okay, non pneumatic anti shock garment. Okay, you can see this one. Okay, this one is asked in your this image based question. Okay, this IBQ. Okay, this IBQ image based question is asked in a NORCET-8. Okay, or NORCET-8 they ask it regarding the anti-shock garment. We call that one as, in a simple term you can call this one as anti-shock garment. Okay, anti-shock garment means it will compress the all okay peripheral vasculature. Okay, and will push the all blood towards the vital organs. Okay, that's what we call as this image is of the anti-shock garment. Okay, anti-shock garment. Okay, that is nothing but a non-pneumatic. Okay, non-pneumatic anti-shock garments. Okay, so we can give a full compression. Okay, with the inflated of the garments. Okay, we can inflate the garments. Okay, we can put the pressure on the all your peripheries, so the all blood will be pulled out to the vital organs. Okay, that's regarding the, it's also used in the severe refractory. In case of refractory PPH, we can use the anti-shock. Okay, sorry, anti-shock. Okay, non-pneumatic garments can be used in the refractory. This one is actually acts as the main management. Okay, as used in the refractory management of the shock. Okay, shock management also we can use the no anti-shock. Okay, in the shock management also we can use the anti-shock garments. Okay, and okay, and again further it fails. Okay, further management fails. Okay, they can go with the uterine packing. Okay, so Cellfox is the brand name. Okay, Cellfox. Okay, Cellfox is the brand name used for the uterine packing. Okay, uterine packing. Okay, they will pack the they'll pack the uterus, okay, so that it will arrest the bleeding, okay, it will arrest the bleeding, okay, it will arrest the bleeding, okay, that's why we can use the uterine packing also. So best be careful. Okay. So after arresting the bleeding, okay, we have to after 78 hours, after 72 hours, okay, we have to remove the packing. Okay, we have to remove the packing. Okay, if not removed, what will happen? There'll be a shock. Okay, there'll be a shock. We will be arresting. Okay, so that's why we have to see. Okay, and next one. Okay, so we can as a surgical option. Okay, we can go with the UAE. Okay, UAE nothing but the uterine artery embolization surgery. Okay, what they will do? They will do a so if you see the branch, okay, if you see this one is the abdominal aorta, okay, main branch, okay, first one, there will be a common iliac artery, okay, so this one is the common iliac artery, again it will divide into the, so again, okay, so this one is the abdomen aorta, okay, this one is the abdomen aorta, this one is the common common iliac artery, and this one is the external iliac artery, okay, external iliac artery, and this one is your internal iliac artery, okay, so main branch is internal iliac artery, okay, so main branch is internal artery, so it will again divide into the uterine artery. So here is the uterus. Okay, here is the uterus. Okay, so this will apply to the uterus and the ovary. So this is what the main branch. Okay, so what one we can like it. Okay, we can do a coil embolization. Okay, we can cut off the blood circulation to the uterus. Okay, so what we can do is we can do a coil embolization for which arteries are preferred. Okay, we can do a coil embolization for common iliac artery. In case of severe case, okay, common iliac artery and then uterine artery. Okay, preferred is uterine artery. Okay, first one. Okay, first choice will be like any artery embolization means okay in the PPH in the refractory PPH we can have the option of uterine artery. Okay, uterine artery is preferred. Okay, very important to know regarding the uterine artery. Okay, so uterine artery is preferred. Okay, uterine artery embolization is preferred in the refractory PPH. Okay, uterine artery and the ovarian artery, okay, and the ovarian arteries. Okay, these three arteries are preferred for the ligating, preferred for the embolization surgery. Okay, this one regarding the uterine artery embolization. Okay, next one. Okay, I told you cell salvage. Okay, means okay if this one is a female, okay, they will do a LSA surgery. If so much bleeding is there, okay, they will take the all blood, okay, and they will centrifuge. Okay, they will add the anticoagulant. Okay, in the reservoir they will add reservoir bag, and they will wash with the saline. Okay, they will wash with the saline and they'll centrifuge and they'll waste will be collected and the blood will be collected and the remaining blood will be re-injected. Okay, the remaining the filtered blood will be all filtered blood. Okay, all filtered blood will be recirculated to the mother. Okay, recirculated to the mother. We call that one as a cell salvage. Okay, cell salvage technique also preferred in the management of PPH. And next one, okay, multiple blood product transfusion. Okay, so we know that okay, if there is a as a shock management, okay, so PPH ultimately what will happen? The mother will end up in the shock. Okay, as a shock management, okay, as a shock management, what will do? What will do? First, I told you, first we'll go with the IV fluids. Okay, first we'll go with the IV fluids. If there is a more than 2 liters requirement is there. Okay, so if we cannot give the fluids more than 2 liters, okay, because it will cause the coagulopathy. So that's why we have to avoid the IV fluids more than 2 liters. Okay, if again requirement of blood volume is there. Okay, so much of blood volume is lost. Okay, so much of blood volume is lost. Okay, so that's why we have to replace that blood volume. Okay, we have to replace the blood. Okay, how we can replace? We can activate the multiple blood transfusion protocol. We call that one as multiple transfusion protocol. Okay, multiple MTP can be, we can activate the MTPs. We can activate the MTP if there is a more than, okay, we can activate the MTP if there is more than 1 liter. Okay, more than 1 liter blood loss is there. Okay, more than 1 liter blood loss is there means we can activate the MTP. Okay, what do you mean by MTP? MTP is nothing but if you're giving the more than 10 units of blood. Okay, if you're giving the more than 10 units of blood within the 24 hours. Okay, within the 24 hours, we call that one as MTP. Okay, criteria for MTPs. Okay, and if you're giving the more than 4 units, okay, more than 4 units of blood within the 4 hours. Okay, within the 4 hours we are giving means we call that one as multiple blood product transfusion. Okay, and if you're replacing the more than 50 percentage of blood volume, okay, if you're replacing the more than 50 percentage of blood volume, you're replacing within the 1 hour, within the 16 hours, we call that one as we call that one as multiple transfusion protocol, or else we can say more than, okay, more than 40 ml of blood. Okay, more than 40 ml of blood. Okay, this one is especially for the neonates. Okay, this one is especially for the neonates. Okay, neonates. Okay, more than 40 ml of blood volume is given means, okay, we call that one as multiple transfusion protocol. Okay, and like in MTP, what will give? Will give a balanced transfusion. Okay, we call that one as balanced transfusion. Okay, we call that one as balanced balanced transfusion means we'll not give only PRVC. We'll go with the 1 rest to 1 raised to 1. Okay, 1 raised to 1 raised to 1 means 1 PRVC. Okay, we'll give a 1 PRVC. 1 PRVC will give a 1 FFP. So, okay, we'll give a 1 FFP and we'll give a 1 platelet. Okay, that may be RDP. That may be RDP. That may be SDP. Okay, that's what we call as a balanced transfusion. Okay, 1 PRVC, 1 FFP, 1 platelet means all together. Okay, all three component differently will give. Okay, will give. That's what we call as multiple transfusion protocol. Okay. So we'll see next one. Okay. As a supportive care. Okay. As a supportive care. So now, okay, you've been like successfully revived the now you successfully been revived the mother from the PPH. Okay, now what we'll do as a supportive care, we have to, okay, we know that, okay, so there is a so much of already blood is lost. Okay, we have to replenish. Okay, we have to replenish the replenish the iron stores. Okay, we have to replenish the iron stores in the body. How we can replenish? Okay, so up to 6 to 12 weeks. Okay, up to 6 to 12 weeks, we have to give a iron and iron plus folic acid supplementation. Okay, iron and folic acid supplementation is preferred. Okay, folic acid supplementation is given for up to 3 months. Okay, up to supplementation can be given as a supportive care. Okay, we have to replace the iron stores. Okay, that's mean regarding the iron stores. Okay, and healthcare systems. Okay, and health system intervention. Okay, we have to, like any hospital, they have to formulate. Okay, they have to formulate the all protocols, all hospitals. Okay, they have to formulate protocols and guidelines. Okay, and guidelines for managing. Okay, guidelines for early detection, early diagnosis, and prompt management of PPH. Okay, and then they have to formulate the policies. Okay, they have to formulate the policies for a referral services. Okay, referral services. Okay, if the female requires, okay, a tertiary level of care, so they have to like follow up with the referral services. Okay, early referral service. Okay, that's regarding the PPH management. Okay, thank you all for carefully listening me up to 1 hour. Okay, if there is any doubt, okay, I'm there here to solve your doubts. Okay, you can like I'm available on the any WhatsApp channel. Okay, on any YouTube. Okay, you can just drop a message in the comment section. I'm there to solve your doubts. Okay, keep on studying, keep on learning. Okay, so actual preparation is you have to prepare with the updated knowledge. Okay, how to be with the updated knowledge. Okay, everyone will study, everyone will read out. Okay, but everyone will not be updated. Okay, if you are updated, you can crack the any examination. Okay, thank you for watching it. Keep on learning, keep on studying. Happy learning.